Welcome, everybody, and good evening, and welcome to this event this evening. Thank you for sparing a couple of hours, maybe, of your evening to spend this time with Baba and myself, talking about something that is very passionate to our hearts, and it's mindset, getting our mindset ready for the future. So my name is Dupe Akomolafe. I am what I term a retired NHS GP who now works solely in the private sector. I run Christchurch Health Centre with Baba, my husband, who is the superintendent pharmacist in Christchurch Pharmacy. So Christchurch Health Centre, as I said, it's family-run business. It incorporates Christchurch Pharmacy, Christchurch Clinics, which I run, and Christchurch Cares.
You're going to show that on the video.
And yes, we'll walk you through the clinic side on the video. And we've been married for 25 years, happily married for 25 years. And I would say that our relationship spans from bedroom to boardroom and everything in between. I'll leave that to you. And yeah, it's been good. I now work solely in the private sector since leaving the NHS. And here we are. So,
should we do the slider?
Yes, we're going to put a couple of questions up on the Slido, and if you can just scan
the Slido as you arrive, we let more people arrive in.
Yes, it should
take you to.
There's a code, I think. And they're just a couple of questions, just so that we get a feel of the room, get a feel of how people are thinking or feeling about.
Don't overthink it.
No,
just say the first thing that comes to your mind.
Yeah, so Baba's going to put some.
I can see one person typing already.
Yeah, exciting. I like that.
Yep. Okay.
Challenging. True. Change. Very true.
Yeah. Please keep them coming.
Uncertainty. Innovation. That's one of Baba's favorite words.
Just keep them coming. Okay. If you're just attending, you're welcome. My name is Baba, and you're here with
Dupe Akomolafe,
my wife. We both run Christchurch together. Okay, exciting opportunities.
Yes. Yeah.
Uncertain and uncertainty together. So it's quite diverse, but still, as we can see, we're sensing the mood of those who are already on the chat today. Okay. All right, so we will move to the next question. Okay, lovely. But do you want to take a photo of this?
Yeah.
So we've got a record. Yep.
I'll just take a photo of that.
Lovely.
Yeah.
And then I'll go to the next question. Thank you so much for doing that, guys. Which of these best describes your current mindset about the future of our profession? Again, just take one answer and we'll see where we're at. Lovely, thank you. Please keep them coming. Thank you.
I feel excited and ready for change. I'm hopeful, but oops. Yeah.
Yeah, that is going to change, isn't it? It will just let people keep. Yeah.
Yeah, I think people are joining in as we speak, more people. I'm hopeful but unsure how to move forward. Fair enough.
If you're having any problems, please type in the chat. We got support from Helen. Okay. Yeah, Helen's typed in the words in there. So
Okay.
In the chat. But if you have any problems, please let us know. Okay, look, it's a 50-50.
50-50, yeah.
All right, so we're going to move on from that. Okay.
Cautious and waiting to see what happens.
Yeah.
So, take a photo.
We didn't mention what we're going to do with questions. I think we're going to wait till the end, but I'll see how we get on.
Yeah.
I'll see there's a pause break where I feel we might be able to address the questions, but any pressing thing, just type it in the chat. We may not be able to address it immediately, but we will. Okay, and then the last question for me, on the scale of 1 to 5, how confident do you feel in your ability to lead or adapt to the future direction of pharmacy? Mm-hmm.
That's an interesting one.
Mm-hmm. Mm-hmm.
It's interesting how the slider.
Yeah,
Yeah.
Yeah, just take another photo.
I'll take another photo.
Thank you so much for your contributions on that Slido. And then I'll just take you back to the, thank you very much. I really appreciate that, Duper, and I do. Okay, fantastic. And we'll refer to that. And then, okay, so that is the Slido done. And Duper is going to take you over to you, Duper. I'm just going to show. Okay,
yes. So that's us. As I said, we've been married for 25 years over. I know I look younger as Baba gets a little bit grayer, but never mind.
Okay, and then you're moving on swiftly. You're going to talk about
yes. So this is Christchurch Health Centre, private health centre in the centre of Braintree. So we have the Christchurch clinics, the cares, and the pharmacy. So I'll walk you through the clinic. That's where patients arrive. It's the lobby. That's the reception where my admin staff are. And this is the waiting room when they're waiting to see me or any other healthcare practitioner. These are our consulting rooms. That's me at work. And yeah, those are some of the services we offer. We have a very large vaccination bay. We did a lot of vaccination, or we still do a lot of vaccination during the COVID campaign. So that's the health centre. The pharmacy, which is part of the health centre, is located on a different site, which Baba will show you during the talk. And we have a care agency, domiciliary care agency, upstairs. So the clinic and the care agency share the same building. So that's upstairs, and that is run by a manager, but Baba and I have a supervisory role. So that's us in a nutshell.
Lovely. And
over to you, Baba.
Okay, so we are hoping to cover these learning outcomes and why mindset matters now more than ever, how to let go of the just a dispenser identity, how to shift to patient-led services, how to become a clinical trusted frontline provider, all to help us future-proof our pharmacy in these difficult times. Yeah, sound good. All right.
Yeah.
So, first question, will your current practice model survive the next 10 years? I think that's a question that I asked myself, and I thought I would present it to colleagues to consider. You can see on your right, on your left there, Blockbuster Video, who we all remember fondly from the high streets. And we all know what's happened to the Blockbuster videos now. Netflix is taking over because
They've been busted.
they've been busted because technology is taking over. We used to make a lot of international calls, didn't we? To our parents, costing us a lot of money. Now with WhatsApp, FaceTime, you get these things done for free. What we're trying to do here is help us to recognize that the things going on is not just a pharmacy thing. There's a
change.
There's a
shift.
There's a shift. There's a shift, and we need to shift with that. Landlines, we don't even know where our landline is. You know, and they will disappear very soon. I tell my age, but I'm one of those who always wanted to work in a Lloyd's pharmacy. Anybody said to me that during my career, Lloyd's pharmacy will disappear, I would have said, no way, you know. But there you go. They're saying, people are going to be saying, do you remember Lloyd's pharmacy? Because it's no longer in existence. So my hope and prayer is that nobody ever says, do you remember Christchurch Pharmacy? Or do you remember your pharmacy? But it's in your hands, it's in my hands by asking myself, how do I remodel with the times? That is the big question. Now, we're going to do a reality check. What I've got here, I've got 3 slides to show you the opinion, not my opinion. First one of the CPE, Community Pharmacy England. They published this it's still on their website in 2023. If you read what's on the screen there, it says, over the course of the next decade, community pharmacy will undergo significant transformation, becoming central to the delivery of joined up, responsive, and person-centered community-based health and care services. So this timeline is already 2 years gone.
Yeah.
And they're talking about significant transformation, and that vision is got to do with the Nuffield Trust and the King's Fund. That's not my opinion. That's what CPE, who negotiate for our funding, are saying, that's where they expect pharmacy to go. This is the latest. I had to update my slides yesterday when I read this this week. Stephen Kinnock made these comments in quite a few of our journals. But the first paragraph just says a lot to me. But did you want to read that first paragraph?
Yes. It says the take-up of Pharmacy First is not what we would like it to be. So we are looking at options to increase awareness of Pharmacy First and to free up pharmacists to be able to operate at the top of their license.
Yeah. Now, I know there's a lot that could be done to improve Pharmacy First for us, but that's not what I read in that first paragraph. It was the last words. He said, to free up pharmacists to be able to operate at the top of their license. The implication coming from someone who has a say in funding us is we're not operating at the top of our license. And that's a biggie when you think that they're going to consider where the money is going to go and who's going to spend the money on not someone who's not. Okay, so but again, that we saw the CPE's opinion, what they put on the website and what they're negotiating with. We've seen what Stephen Kinnock, who we will be negotiating with in the context of the government, what they think about us. Let's go back to school. Now, I got this from one of our staff, Naushad, who recorded this from a lecture on the 1st of October last year. And now you're going to have to forgive me. This slide, I don't know if it's a virus or whatever it is, it's going to just go skewed. However, I need you to please listen carefully to the words of the lecturer. Everything she's got on the screen here, I have duplicated it on the left. So that's what she's referring to. So I'm just going to let it play, and you're going to see this thing just swing along.
It's also predicted that in the next 5 years or so, that pie chart will change, and that probably the blue bit will probably be about 50%. And so you'll get 50% of the income from prescription volume, and the other 50% would be services. So if pharmacies are too resistant to change, they risk actually, putting themselves at risk of kind of being closed down and things like that.
So she says 5 years. From last year, we got 4 years in her opinion. So we've listened to the CPE, we've listened to the government, and now this is what our undergraduates are being taught to say that we need to look beyond dispensing, because that's only going to amount to 50% of our profit from the NHS very soon. The other 50% is going to be services. So we have to ask ourselves the question, is my pharmacy got the mindset to prepare me for this change? So what we're going to do is take us through, and some of you may have seen this in the advert, but this is a journey through our pharmacy. It's not perfect, but what we want to show is our direction of play, why and what we have been doing.
Maximizing what we have.
What exactly? What
maximizing the most of what we have.
Correct. I'll just let it play.
This is Christchurch Pharmacy. Where we are right now is the collection point. Coming to our pharmacy, and to your left is a collection point where you, as a patient, have come knowing you've got your medication ready. You may have received a text or notification from the app. At the collection point, our staff are trained to see if there are any opportunistic services that they can actually offer you, say NMS, hypertension. What our strategy is this: we feel that the workload in a pharmacy can be very broad. So you've got people coming for various reasons. If they're all coming through the same channel, say, for example, you've just got one counter, as it were, serving everybody, it is difficult to have what we're calling strategic workload management. Now consider the fact that you are able to take your workload and spread it across a wider space, say a collection point that's separate from your reception. Now, at the collection point, you now have a greater capacity to think around the patient than the task, enabling you to do a lot more without contact. So here we are in the reception of our pharmacy. You would only come this far if you've not just come to collect a repeat prescription. Remember, we showed you the collection point earlier. You can see we've got a wide reception, so we can serve as many patients at the same time. Those who come into the pharmacy may have come because they've got an appointment. They may have come because the GP has sent an electronic prescription over to us, for which they want to wait. Or those who need to be seen by a pharmacist will get you, the patient, to scan the QR code, and you can take a seat. If a patient comes in and tells us that the GP has sent an electronic prescription to us, we use the opportunity to provide other services, such as the blood pressure service or the cholesterol testing service. Because of our ability to strategically manage our workload, our staff at the reception have the time and the capacity to offer these services. And so, welcome into our dispensary. This is one of our stations. Behind this wall is our robot. And on the screen, we've got an AI-driven software. I click of a button, it asks for all the items that are on the electronic prescription from the robot, and that gets delivered into the chute for our dispenser. All they need to do is scan the QR code of the product, which will print a label accordingly. No need for accuracy checking. It goes straight into the bag ready to be put on the shelf. It doesn't get any easier than that. The reason we're able to get blood pressure done within 5 minutes is because we use an electronic blood pressure machine, but also we get the patient to actually enter their data on our iPad by themselves. So we give them the iPad, they fill the form with their details, take a sit, and when they're ready in 5 minutes, we take them into the room. And that saves us staff time in being able to deliver all that we need to do, allowing the patient to do what they can do to help us serve them. Behind the reception is access to our consultation room. Initially, we only had one consulting room right here. Over here were shelves of things we sold over the counter. When we realized that we needed more consulting rooms, we took that counter off and created access to an office behind which belongs to the practice manager, and we converted that into a second consultation room. We are in our consulting room, which is under construction. We have carved out this space from our collection point. This wall belongs to the blood pressure room that I showed you earlier. And what we've done here is convert an area we used for blister packaging to a consulting room. Over here, in a few weeks' time, is going to become a door entering into a third consulting room. Because now, as part of the IP Pathfinder, we need to be able to house our IP in this space. Hence why we're constructing another consulting room. Okay, so that was a tour around our pharmacy. I hope it inspired you to cope with the fact that we need to change. It's either we reform or we get reformed. I've settled it in myself that I've got to embrace change. That's why at Christ Church, we had to deal with changing our mindset, our mission, and our model. And in changing our model, we had to look at our premises, like I have shown you, change in our personnel and our practice. And in that way, we're able to strive to be the pharmacy of the future. Lovely. Okay, I can see that Hema has got a question. Are you able to unmute yourself and speak, Hema?
I think I can now. Yeah, I'm sure you can hear me. Yeah, hi. Lovely video, Baba. As you know, I too am changing systems to AI, one that uses AI to check things. One of the challenges I'm coming across is flagging other services. So in our old system, because it's all paper tokens and stuff, everyone would write on there, do a pill check. Can we do it or whatever? I know NMS is quite easy to flag, but what about things where you might need to look at patients' sort of PMR as such? So, for example, I'll give you an example: is that blood pressure checks on handout, because the AI system is paperless. How do you flag this person could still have a blood pressure check without knowing their history? Or do you get your dispensing team to do that?
Well, the thing is, we're all still learning, but what we're finding is shifting the way we're thinking to the new software. While we're doing the clinical checks, you can actually leave a message on the bag label. Did you know that? Well, we might be speaking of different softwares, and I'm being very careful because we're not here to advertise any particular software, but I do know we're using something similar. So as yourself. So they're very user-friendly. While you're doing clinical checks, you could actually narrow down and put those messages so that it comes out on the bag label. And the pharmacist who really isn't getting involved in the dispensary anymore gets enough time to actually put that in reviewing that. That might not be the perfect way. If you learn a better way to do it, Emma, you got my number. Please let me know, because we all are trying to achieve the same thing. Does that help?
Yes, it does. I was just wondering if you have found any new ways, and we're training our dispensing teams now to also look for these opportunities, because as you know, in the AI checking or clinical checks, you could probably save it for up to a year, and you might not see it again, and you might have missed opportunities. But now it means that the whole team has to get involved in sort of flagging, not just the pharmacist anymore, or not just the ACT anymore.
Absolutely. And that's where mindset comes in, Hema, and the rest of the crew. Because if our team look at dispensing as the end of, then they miss those things.
Yeah.
But once they realize that 50% of the income with which we will be able to pay your salaries and is going to disappear. But when the lady from the uni was speaking, she wasn't saying that the workload was going to reduce. It's the profit. Dispensing will continue to increase in workload. So it's us making the money off dispensing from something else. And so you're right, Hema. We need to find ways to make sure we capture every opportunity, we make every contact count.
And just to add something to that, Hema, is even just asking I mean, just asking the question.
Having the conversation.
From the clinic side of things, for example, at the moment we have a lot of clients coming in for travel vaccines for their kids. Kids are coming in because they're all going on the World Challenge. So I don't know if it's something you have had as well. And so they're coming in with a parent. So I say to the team, yeah, they're sitting in the reception. Why aren't you asking the parent if they need a blood pressure check? Yes, it's the child who's come for a jab, but what have you asked the parents if they need a blood pressure check? So it's that making every contact count. You know, sometimes a carer brings somebody for microsuction. Why haven't you asked the carer if they need a blood pressure check? But I find I have to keep reminding the team. I have to keep reminding. So they'll do it, you know, first thing in the morning, and then by 5 o'clock today we missed 2 that I grabbed. You know, so it's just that constant change of mindset, isn't it? You want it to be what they're thinking about.
That's it. And it can be tricky, you know, but it's a journey where we're reinforcing that mindset. And our journey of leading our team has brought us to the realization that it's not that they don't know, it's about the mindset changing to what we now are, so that we can thrive as a business. But thank you very much for that question, Emma.
No problem. Thank you.
Thank you. So how do we reform our pharmacy beyond script? I think we kind of alluded to that it can only happen with a change of mindset. That's the only way people can see opportunistic services. Otherwise, you're just going to see, oh, Mrs. X has come to pick up medicine Y.
Yeah.
And you give out the medicine Y accurately, and you think you've done a job. You have, but it's not going to pay our bills. It's about everything else that we're able to pick up. So we've got to adjust our mindset. We're going to explain that further. You cannot change your mission without changing your mindset. We always rise and fall with where our mindset is. So wherever you need to take the team, you got to take them there in their minds first, on that mission of what you're trying to achieve now, that we're going beyond scripts. And then you change the model accordingly, because sometimes you want to achieve things, but the layout doesn't actually allow, the staffing levels or the staffing type doesn't actually allow for that to happen. So we're going to look at each of this, but I thought I've got some. Okay, so when we considering a change of mindset, what do we actually mean? Let's start from the top. How do we see our profession? If I see myself as a retailer, what's the likelihood that I will be able to see myself as a healthcare practitioner, healthcare provider? So are you a retailer or a healthcare provider? Now, this image has come from, well, Boots is a retailer, and they were the top in our business. Lloyd's was a retailer. they did pharmacy on the side. So here comes a new season where pharmacy is expected to be a healthcare hub. And we need to start seeing, how we juggle that hat and spend more time having the hat of a healthcare professional on than being selling retail stuff. How do you see your premises? Do you still call your premises a shop or a healthcare hub, or at least a pharmacy? We call ourselves Christchurch Pharmacy and Clinics, and under the umbrella of Christchurch Health Center. And that image, it goes a long way. How do we see our users? Do we still see them as customers? When they go to the surgery, they're called patients. They pick up their prescriptions, they come to us, we call them customers. Now, every retailer calls them customers, but only healthcare providers call them patients. So they come to us, we call them patients. They go to their hairdressers, and the hairdresser calls them a client. It's interesting what happens at Christchurch, because people come to the pharmacy, and we call them patients, and then they go to see Dupe and they call clients, because at the private clinic, they spend a lot more money, and they could get a cup of tea if they want one.
But biscuit.
Yeah, so they're clients over there. How do we see our users? The importance of this is that the way we see them is the way they see us.
Yeah.
You see, people going to a place. Did you want to give an example of the lady who came for
vaccination? Yeah. So I had a travel vaccine consultation with a young lady, and as I always do, I just asked, "Oh, how did you hear about us?" Because I always like to know, how our adverts are getting out there. So she said, "Oh, I had actually been somewhere else to have my vaccine done further away." So I said, "Oh, okay. Do they not have the vaccine?" She said, "No, actually, I sat down to have my vaccine and I just couldn't." She was like, "I sat there ready to have the vaccine and I just had to say, stop. I just couldn't." So I said, "Oh, why is that?" She said, "Just the way the place was, I just couldn't. So I just had to apologize and leave." So, so she said, "Well, then I found you online." She said, "And you're not the cheapest." So I said, "Oh, okay, that's interesting." I said, "I hope we haven't let you down." She said, No, it's great. I'm really pleased. But, I came back home and I said to Baba, I said, "How bad could it have been that somebody was already sat to have the vaccine and you actually stopped the practitioner?" I thought, how bad could the place have been? But, that's a patient client's perspective. And yeah, it was very interesting. Yeah.
Did you want to do this one as well? How do you, healthcare professional?
Oh gosh. How do healthcare professionals, how do GPs see pharmacy? Well, I think I wouldn't count myself like this, because obviously having worked and lived with a pharmacist, on most of my life, I have a different perspective. But I think generally, GPs see pharmacists more as retailers. I think they see pharmacists being more as it's what they can sell rather than providing a service or. Yeah, and I think that's where that perspective of they're my patients, comes, rather than, and because we don't own the patients. Let's be honest, as a GP, you don't own the patients, but we don't see pharmacists generally as somebody that we're sharing care with. On the other hand, secondary care practitioners, you see them as, that. But yeah, I think it's changing slowly now with the introduction of Pharmacy First and so many other services that pharmacists, I think GPs are now being forced to see pharmacists differently. But yeah, I think that general view is still quite predominant amongst a lot of GPs.
Okay, thank you for that, Dupa. And that also influences how commissioners see us.
Yeah.
There's this saying that can you commission from a shop?
Yeah.
You know, so we've got to look at how we see our profession, how we see our premises. We see them as patients and we provide the service in such a way that the GP see us as shared care professionals. And hopefully that will bring a lot more contracts our way. So we've got to consider the change of our mindset and then the change of mission. Now, as a retailer, the first thing that comes to mind is to make every sale count, because they come in, I want them to spend money on something, take it up, buy it off the shelf. However, where we need to shift our mindset is to be prepared for every contact, because opportunistic services come and they go. If you're not prepared mentally and also in the layout of your pharmacy, it's very difficult to make every contact count.
Yeah.
Yeah. You can only make every contact count to the level of which you're prepared for those contacts. Sometimes some of them are already coming for a COVID jab, and we could do blood pressure from that, and that blood pressure could lead to ABPM.
Yeah.
And potentially lead to an NMS.
Yes, actually, something that happened during the COVID campaign, which one of our staff, she took her own, her own initiative did, and I was really pleased because that tells me where her mindset is. Was that she looked at all the clients coming, because we print tokens, appointment, so we know when they come, we just scan it. So she looked at all of them. She looked at the ages, and she decided that everybody under the age of 60 could potentially need a blood pressure check. Yeah. So I said to her, well, how did you work that out? So she said, well, I've noticed that most of the over 60s tend to already be on blood pressure tablets. So I'm just going to make sure we don't miss anybody under 60. I'm going to target. Between 40 and 60. I'm going to look out specifically for these ones. I'll still ask everybody, but I'm going to look out specifically for this one. And that told me that her mindset is changing. She's thinking, yeah, we've got to think about blood pressure.
Right.
We were doing COVID jabs. We were not, doing a blood pressure campaign.
But a COVID jab of £10 can then become, at that time, it was £15 blood pressure, and then could become ABPM, and potentially could become a cholesterol test for £30, and all of a sudden,
absolutely.
All of this, there is no clawback, there is no category M.
Yeah.
What you get is what you get. And that's the beauty of our services as opposed to the transactional retail and dispensing. And then finally, following up every contact.
Yeah.
There's something that our clinic do so well.
So with when we have clients who have microsuction, for example, I've set up the clinic software in such a way that we have templates. That's just templates there, letters, templates. So as soon as I don't do the microsuction now, I have a healthcare practitioner who I've trained to do the microsuction. She's also a dispenser. So what then happens is, as soon as she's done the microsuction, my admin staff just would send a letter. So all Hannah would say is she'll say both, or one, or left, or right, and we know what she means. As soon as Emily hears that, she sends a letter to the GP saying, we've seen your client, your patient, we've done microsuction, both ears were done, successful, whatever advice was given, send. I'll tell you something, as a GPs, they moan about paperwork, we moan about paperwork. But a GP loves it when the patient has been somewhere and they have information to say this is what has been done. They just love it, because patients are very poor historians. So if the clinic or the pharmacy has sent a letter to say this is what we've done, they love it, and it's free advert. What's happened also is that because we do that so regularly, it's increased our credibility amongst the local surgeries. Now, when the patients turn up and for travel and they can't do it, they just say, go to Christchurch. Microsuction, if their patient asks, Do you know where I can get that done? Go to Christchurch. You know, in fact, sometimes minor surgeries, they turn up, go to Christchurch. I'm like, hey, Christchurch, I know we do some things, but we don't do everything.
No.
So
there's a lot more that we
Good
can
idea.
also do with regards following up every contact, and we're discussing that as a team to see what we can make our next steps. Now, a change of model. So remember, what we're trying to do is consider the change of mindset, which without that, nothing else is going to work. And so that we can change our mission. And then, of course, you're going to need the right model to carry out that mission. Because if the layout and everything is not right, and now underneath the change of model, we're going to consider the premises, personnel, and the practice. This was our premises some years back. As you can see, our tenor lady there that was not shifting, and you can see our health monitor here. At this stage, we were not commissioned to do blood pressure, so I used to get £1 and share it with that company when a weight and height and blood pressure is done, and they put some coins in there for me, you know, so I could pay my school fees. But hey, it just occupied a little bit of space there. And so what we did was we gave the tenner to a charity at a hospital nearby, and we decided to pull down that wall. And this is a bit of the staff room. That's where I used to pay the bills. We extended that out and created the now collection point. At that stage, we had this collection point here and another window that allowed us to do the queue busting when there were lots of people. But at this stage, we were now able to strategically manage the flow coming in. But we had to give up the tenor and a few things that we thought we couldn't compete anyway, so that we can focus on the things that we can. But it was only a matter of time, just to show that we're still evolving. Okay, it was only a matter of time, because now when you see from that video, this window here has now become the new blood pressure room. And that was only because since our pharmacists were no longer working in the dispensary and doing more pharmacy first and things in the consultation rooms, and even when we picked up an opportunistic blood pressure, there was nowhere to take them to because the pharmacist was on the phone or whatever. So by cutting out that space, we'll now be able to catch our blood pressure patients. So that's kind of the journey. We need to innovate our premises. So we're talking about the premises, personnel, and the practice. We need to increase the space for services, improve the appearance of our consultation rooms. Now, not everybody can find space in their business like we've been able to carve out a space for our IP, and it is a struggle. We were able to CQC register our premises on the high street for private services, but we're hoping that our negotiating bodies will speak to the GPHC to consider helping us
offsite premises.
Register offsite premises. GPs use hubs, so they use satellites, they use various ways to. In fact, I have this story. At one stage, we still are actually in partnership with a local GP surgery to provide training to our foundation trainees. At one stage, that GP surgery didn't have any room for their IP pharmacist. What happened was that GP surgery rented a room above another pharmacy where the IP pharmacist worked. Our pharmacy trainee leaves Christchurch and goes to a room that's let out by another pharmacy to actually be trained by a pharmacist who's paid for by ours funding to a GP surgery. I'm sorry if I've confused you, but it is that confusing. Why didn't the funding go to that pharmacy?
Yeah, true.
Because the GP doesn't have room. And this is the danger for us, and I will explain that later so I don't get myself all worked up. I'll explain that later, but we need to see how we can create more consultation rooms because we're going to need to accommodate more pharmacy first services. What if they offered us ours funded? Where are you going to put that pharmacist? We need to think ahead to make these significant changes as referred to by the CPE. We need to innovate our personnel, innovate the dispensing process so that they have capacity. A lot of competence that our ACTs have, our pharmacists have, they can't use it because they're busy doing the checks. They're doing accuracy checking. But if you innovate your accuracy checking, that frees them to utilize those competences. The capability, now, we don't call our staff counter assistants, we call them receptionists or admin staff. So when Dupe was referring to the fact that Emily would or Kirsty would work on doing our admin for her, that whole thing, they don't have the capability to do that because they've got their computers and everything to man those services, book appointments for patients, and finish up for the health practitioner.
And my Hannah, my dispenser, who
is also the healthcare.
She's now the healthcare. She's also the healthcare practitioner. She runs her own diary. She has her own microsuction diary. She has today I was counting. She has 48 appointments slots a week. That's huge. That's a lot. So yeah. And she loves it because she, on one side she's a dispenser. Her work, her job has suddenly become far more interesting. You see.
But everyone's roles vary, those in the dispensary and in the clinic. But we're upskilling everybody to do more because the computers are doing the mundane things like dispensing. So considering collaboration as well, because pharmacists, we have been trained to work in silos, but there are other things that if you did have the space, that an audiologist, an osteopath, which we used to have until we got too busy.
We had an audiologist as well.
It looks good on your presentation that you're more than just a dispensing factory. And there's money to be made there, but it's not about the money. It's about the collaboration and showing that we are a health center.
And their clients become your clients as well.
That's right, vice versa.
Yeah, and vice versa. Counselors, we've had counselors as well.
We have. And I met a young pharmacist the other day at the Avesina conference and training day. And he said he's going into partnership with a dentist to run a private pharmacy. And I'm like, whoa, people are thinking, no NHS contract, because anyway, I wouldn't go there, but we all need to consider beyond the streets. Otherwise, everyone's pointing in the direction that if we keep on working below our license, we will lose out. Okay, so and lastly, we need to innovate our practice. Automate your dispensing. If not, consider hub and spoke. You're outsourcing your dispensing to leverage on the investment of other companies who've got these automated things going and they can dispense for free, for very cheap. But if you can't afford a robot of your own like we have, you may want to consider that, and opportunities will come up in October. But you need to start having conversations now. Digitizing our pre-consultation and delegating admin work, that's only possible if you've got electronic forms, because when Dupe does and Hannah does clinics, if they're not digitized, then you're going to have to be manually doing a lot of things. But we've all seen how helpful a pre-consultation form with flu jabs can be when the patient has already actually done half of the filling.
It cuts down the consultation time massively, and that's why Hannah can now have that many appointment slots, really.
And it speeds up, as I showed you in the video, our blood pressure process. Okay, there's a lot more as far as telehealth is concerned. It's something that we've not actually looked into, looking at online services that can be provided. So we need to evolve our practice. We're still on the journey. As you could see, our site is not finished. We're changing and moving, but we've got that mindset and we're encouraging colleagues to look at shifting the mindset beyond scripts, because mindset matters more now than ever. We're not just dispensers. We've been expected to provide patient-led services and become clinical, trusted frontline providers. As hospital is coming to community, we've got to be there knowing that the GPs will not be able to handle the workload. So let's future-proof our pharmacy to be able to handle what's coming. The writing is clear on the wall. The government says no reform, no funding. So if we don't reform, we get reformed. And that's not good because they're going to form us in the way we don't want to. So we want to reform, so we're not reformed. It's not just revenue we have to lose. We don't want to lose our relevance in primary care. Now, there's something going on right now with the arts funding. I don't know if you've noticed. There's a drain of our IPs into general practice. If the government sees that we don't have the capacity to upskill our personnel and accommodate us, other pharmacists, they're just all going to go to GP surgeries and our businesses will suffer, and we don't want to lose our relevance. A GP pharmacist is a great job, don't get me wrong, but that is not a pharmacy practice. That is a GP practice that's been helped by a pharmacist. Very few of them eventually become partners. You can count them on your hands, those who become GP partners in the whole country. So we need to save our profession and make things work because our future depends on us. Thank you very much for listening. I think there might be one question in the chat. Did I see? Okay, no, it was yeah. Do you have any questions for Dupe?
You're not taking any questions, I see. Hopefully it was
okay. Is the chat disabled, Helen?
No, you do have one more question. You do have a question. It's which PMR AI system do you use? Oh, they're coming in thick and fast now.
oh right.
I was hesitant. So Helen, where am I not looking? I can't see the questions.
No.
There's a Q&A panel. If you go into the three dots, it should have a Q&A panel. So it's which PMR AI system do you use? That's the first question.
No, not that one.
Okay. Well, yes, I was hoping that I didn't advertise our PMR system.
Okay, which PMR?
Yes, we actually use Pharmacy X, but I am one of those who are saying to pharmacists, can we please not narrow down the competition? If we all keep calling on one name, that name gets so powerful and so expensive, and then nobody can afford it. We need competition. We need competition, and please don't let anybody divide us based on which PMR do you use, which robot do you use. We all need to negotiate and then bring more people into the market, if that makes sense. But to answer your question directly, yes, we use Pharmacy X. What has been the number one pushback from staff? Now, that's a very good question. If we present, because as a pharmacy owner, I'm sure there are people who are not pharmacy owners who are listening. I actually spoke to a colleague yesterday at a meeting. She is a pharmacy manager, and she said head office never tell her what's going on. Jody was saying head office never tell her what's going on. They just come and say, this is what you need to do. You're not actually taking them on the journey. That's why we're saying it's mindset that needs to be addressed first before you take them on a mission and before you change any models. So we found places where a new robot has been installed and they've had to remove it because the staff just don't accept it. So the very important thing to reduce pushback, if not knock off pushback, is to get the buy-in from the team.
Yeah, I think apart from, I mean, getting the buy-in from the team, I think that's also come from years of the relationship with the team. So I know Baba, for example, has a staff meeting every Wednesday. Now this, even when there's nothing to talk about, they have a staff meeting every Wednesday for half an hour. So the pharmacy is shut. No customers or patients can come in, and this have a meeting. The staff have the opportunity to voice their thoughts. Baba has something to say to them, to encourage them. We have this mantra in Christ Church that we call PIES. P for productivity, I for innovation, E for efficiency, and S means that if you adopt PIE, you have job security. So they hear that all the time. So I think when Baba says about buy-in, it's very unlikely that they're going to push back or resist because they've always been carried along, even when there was nothing to introduce. I don't know if that answers the question.
It does, and I'm the one they hear from when Lloyd's closes pharmacies. I remind them of all those things and explain to them why it's not going to happen to us. It's not me, it's not fear mongering, it's me. I bring the news to them. This is what Stephen Kinnock has said, and this is what he's expecting of us, because I don't pay your salaries. I just pass the money that the NHS makes available to you. So if the business doesn't work, then we're all going to lose our jobs. But yes, we didn't get a lot of pushback, but we know we've done a lot of work to prevent that. Yeah. Okay. How do we manage our inventory and deliveries to avoid items sitting on the shelf? Now, the AI system works with our robot and manages the stock that we need. It can actually let you know the medication, the stuff that you're not using, because the reporting system is very, 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 very clear. We got fridge items, of course, which are not accounted for. We need to actually manually type that into the software. But everything we store in our robot, which would amount to 90% of our stock, speaks directly to the software and manages our inventory that way. And deliveries to avoid items sitting on the shelf. Now, with regards the items that we have dispensed awaiting collection or to be delivered, we send a text, and this is something we've done recently. You may want to consider. We've actually been sending a text saying that we will hold your medication on the shelf. No, actually, it starts by saying, we need you to please pick up your medication from us within the next 5 days. If it's not collected, we will be returning your prescription to the GP surgery. Obviously, we're not returning it immediately until after 28 days. But what we found was, once that text arrives, people are coming within 30 minutes to pick up their medication. They're thinking, oh, I thought I might as well pick it up now because I'm actually traveling. I thought I might as well pick it up now. Otherwise, what they do is they leave it on your shelves until they need one more tablet. And then they come just at the very last hour of Friday and expect that you should shut down the shop and give it to them. And you've been keeping their medicines for so long. So that's working. What's our opinion on pharmacy OTC sale going forward? I'm the wrong person to answer this question because
We don't have
We don't
hardly
have.
any OTC.
Yes, we hardly have any OTC. I think if I was any other pharmacist, take a basket, the baskets you pick up when you walk into a shop, and fill it with the average items, okay? And calculate how much time it takes your staff to actually put those things on the shelf, take the payment and talk about the dog and all that they do, instead of blood pressure or any other service, and see how much profit you're actually making from it. So I'm going to ask if Helen could check with the NPA, if anybody could do a calculation for us, members, to see just a calculation of every square meter that we pay rent. The return of investment on having OTC on that space compared to having a consultation room. I think that might help us just consider what we do. But we had to make a decision. If we wanted to provide clinical services, we had to let Lidl, B&M, and who else? Tesco to do the retail sales for us. We do have the PMEDs to respond to symptoms, and that's it. We don't have anything to sell over the counter. Do we charge for MDS? Yes, we do. Is it gone up now? Oh. No, it was 20. I think it's gone. No, it's gone up to 30 recently. Yeah, £30. It's gone. We don't have a lot because a lot of them went away. But we've passed on all our not for profit services to other local pharmacies. Not for profit services like NDS, when they heard the £30, then a lot of them moved on. And then our deliveries as well. We still deliver for free, but we only deliver to those who are housebound. So our deliveries from 115, 120 sometimes a day has gone down to 30 every 2 days. Every 2 days. So, it's those people who don't have anybody to support them. We don't do deliveries every day now. Some patients left, and we've left that not-for-profit service to a colleague down the road.
And on the cost of significant change with the imminent publish of the 10-year plan, how do we raise the government's perception of community pharmacy? We're only as strong as our weakest link. Right?
Thank you so much, Tunde Shokoya, for that statement. Let me be honest as to why Dupe and I are here, and we've taken up the role of what the NPA has invited us to do. We've come to realize that individual brilliance, and I know what you're doing where you are, Tunde, is great, but individual brilliance is not going to get us through as a profession.
Mm-hmm. It
is our collective capacity that Stephen Kinnock was referring to. If he'd been to a pharmacy like yours today, he would be putting an IP there and everything going. But they want to see us step up as a collective. And if those who are doing pharmacy in the futuristic way are not working with the rest of us to actually say, guys, we can do this, and we share ideas. Pharmacy, community pharmacy is like an aquarium. You cannot outgrow the size of the aquarium, but together we can actually build that. So yes, we're only as strong as our weakest link, but the strong are also responsible for the weak in some ways. You can't force anybody, but sharing ideas, meeting up and encouraging our local teams, because we've had situations where a doctor has refused to do pharmacy first anymore because another pharmacy was sending back patients unnecessarily. We've all lost out on MURs for that same reason, for the minority. So we've got to look at how, and with the support, that's why NPA is supporting events like this, how we can bring people together, how you can motivate on the grassroots instead of competing with each other and XYZ. We need to work together to build the perception that patients, other healthcare professionals, commissioners the government have of our profession.
Kosi says, is it feasible for private services alone to sustain a pharmacy and serve as replacement for NHS provisions?
Do you want to answer that?
Well, yes, I think it is. We have been to a pharmacy that is completely private. She hasn't got an NHS contract. Debbie? Deborah in Winchester. She's won 2 awards for what she's doing. She runs, it's fully private. She's got menopause clinics, she's got travel clinics, a lot of private services. I think it's about getting a feel of what the community around you needs. You've got to find out what the needs are in the community, and it's a targeted. It's probably not for every community, but is it possible? Is it feasible? Yes, I would say it is feasible.
Yeah. I mean, but for me, for a pharmacy to come to Braintree and thrive doing just private is a slap in my face. Because if I get all these walk-ins from the NHS, for dispensing, and then they walk out and get their ears done as a private service somewhere else, it means that, so really, I think we should be making the best of both worlds, just like the dentists do. But it is feasible to do a private service alone and hit a market.
Do you see the day we as pharmacy are allowed to provide full GP services and be a GP pharmacy combined service? There have been pharmacies that have taken over GP contracts.
Okay.
I think that's a biggie. Would it full GP services? I think working in collaboration, yes, definitely. To completely take over the GP services, I'm not sure. I'm not sure that I can sort of see that in the very near future, but I think definitely working in collaboration. I think Pharmacy First is such a great idea, and I'm maybe the only reason why I wouldn't say gutted, but I feel like, if I was still in the surgery, I would have pushed on that because I was very active. But I know that if I was still in my local surgery, I would have pushed for us to ensure that we're referring Pharmacy First and supporting pharmacies in that respect.
Can I add to that? Why would you want to do that? Do you know GPs actually envy our contract? GPs want to do private services.
True.
Now, in reality, Dupe she can't do what she's doing today without my license, because I give her the footfall and she runs a private service. But when she was a GP at her surgery, there was conflicts of interest.
Yeah.
They pay your rent, therefore you cannot do anything else in those buildings. If you're doing it, the patients are going to kick off. But for us, we can actually take an NHS patient and turn it into a private service, and no one's going to bat an eyelid.
Yeah, true.
So if you want to go down the GP contract, we're actually narrowing ourselves. What is happening is that we're not maximizing our capacity. We are the winners in this whole system if we see the broad thing beyond just why isn't the NHS paying me more for dispensing?
And I know now a lot of quite a few GPs are actually going into pharmacies and consulting there. Private. So they're running sessions. Most GPs don't want to work full time anymore. They've done that. So a lot of them are doing private work because they can't afford to go and rent a building. So renting a building, CQC registration, there's a lot to it. And I think I'm one of the very few fortunate ones. But a lot of them are going into into pharmacies and using your consulting rooms, because now you lot have consulting rooms and they're taking advantage of it.
And using your footfall as well.
Yeah.
Because all you need to do is put a leaflet out, say you got a
Yeah.
doctor here on Wednesday mornings, and whatever service he's offering that they can't get at the GP surgery.
Yeah.
And so, you know, be aesthetics or whatever it is. It is.
GP consultation.
I think what's happening is, yes, I agree that we need to look at ourselves broader than just the one pharmacist. We can build a team of pharmacists, you know, where you don't have to be the aesthetic practitioner, the ear wax provider, everything. You could have specialist pharmacists who come in and actually work with you.
Yeah.
So there's more that we can actually do with pharmacies.
Yeah, that's what
pharmacists
has in Winchester.
Yes.
She's got a specialist pharmacist who runs her menopause. I mean, she runs it as well, but she runs her menopause clinic. So yeah.
Yeah. Yeah. Okay. Thank you very much for the questions. Duke and I would like to thank you for attending today, and I hope you have picked up on something. Tell us stuff on LinkedIn. We would really appreciate to hear from you. I will.
Yeah, and I don't know if Helen is going to send some feedback.
She's something here.
Is she? Helen, are you going to send feedback?
I'll send the recording out tomorrow.
Okay, are you going to
with all the
get feedback
information
from the participants?
Yes.
Okay, so that'll be great. Feedback, and also maybe topics that people will want to, you know, hear more. I'm sure the NPA will want to know what other topics that people want to hear more about, or yeah. These are turbulent times, but I think the whole idea is that we're all in it together.
That's it. That's it. Really appreciate that. Thank you very much, NPA, for hosting this, and thank you everyone for attending.
Yes, thanks, Helen.
Thank you.